Imagine you've spent, I don't know, a decade training as a surgical oncologist.
Right. A massive amount of time.
Exactly. And your whole instinct, your entire professional ethos is to basically identify a tumor and cut it out.
You see the problem, you remove the problem.
Yeah, you see a mass, you mobilize the stomach, you perform a gastrectomy, you get those clear margins, and you're the hero.
That's the classic surgical mindset, for sure.
But today, we're looking at a gastric cancer where the absolute gold standard first-line surgical move is to, literally put down the scalpel.
Step entirely away from the operating table.
Right. You step away, and instead, you write a prescription for amoxicillin.
It's wild. It completely flips the script on what a surgeon is supposed to do.
It really does. So, welcome to the deep dive. Our mission today is to hand you a true PhD-level mastery of gastric lymphomas.
Because if you are sitting across from your examiner right now, preparing for your FRCS exam, you have to know this inside and out.
Totally. Or even if you're already managing complex cases in a high-volume center, you really need to understand this profound paradigm shift in how we handle these specific neoplasms.
Absolutely. We are pulling from a massive stack of clinical texts and medical literature today to really map out the unique etiology here.
Yeah, we're going to get into the molecular markers that dictate your clinical moves, the really critical differences between the staging systems.
Which is a huge trap on the exams, by the way.
Oh, massive trap. We'll cover that.
Okay.
And finally, we'll build the definitive algorithm for complex refractory cases.
So getting right into it, the transition from aggressive surgical resection to conservative antimicrobial therapy for a malignant neoplasm. I mean, it represents one of the most fascinating evolutions in modern oncology.
It's just so counterintuitive, like treating cancer with antibiotics?
Right. Historically, a diagnosis of gastric lymphoma meant an automatic, partial, or total gastrectomy.
Yeah.
Surgeons were removing entire organs to cure the patient.
Because that was the only tool that made sense at the time.
Exactly.
Yeah.
But as our understanding of the underlying biology evolved, we realized that we were treating the symptom, right, the tumor, but we weren't addressing the environmental trigger.
We were putting out the fire, but ignoring the arsonist.
Spot on. So to understand why we now reach for a proton pump inhibitor and antibiotics instead of a scalpel, we really have to look closely at the normal microanatomy of the stomach.
Yeah, let's ground this in the anatomy first. Because a normal, healthy stomach wall is a really hostile environment.
Oh, it's brutal. It's essentially an acid bath designed for digestion.
Right, with a pH hovering around, 1.5 or 2?
Yeah, highly acidic. And unlike the small intestine, which is, packed with pairs, patches, and those intrinsic immune outposts,
the gastric mucosa doesn't naturally contain any structured lymphoid tissue at all.
None. There are no B-cell follicles or T-cell zones inherently built into that lining. The native environment is strictly glandular.
But the human body is incredibly adaptable, right?
Right, it is. When the gastric mucosa faces chronic antigen stimulation, basically a persistent long-term infection, the immune system essentially builds a forward operating base.
A forward operating base. I love that analogy.
Yeah, it recruits B cells, T cells, and macrophages from the systemic circulation, and it pulls them right into the gastric lining to fight the invader.
So it's building an immune structure where one shouldn't even exist.
Exactly. And over months and years, this constant inflammatory state leads to the formation of aberrant mucosal-associated lymphoid tissue.
MALT.
Right, MALT. The body constructs organized lymphoid follicles right there in the stomach wall.
So we have this newly constructed anatomical structure born entirely out of chronic inflammation. And in up to 90% of these cases, the antigen driving this massive immune recruitment is Helicobacter pylori.
H. pylori, the exact same bacteria responsible for peptic ulcer disease.
Which is crazy because how does a bacteria even survive that acid bath we just talked about?
Well, H. pylori is uniquely equipped for it. It secretes an enzyme called urease.
Okay, urease.
Yeah, and urease converts urea into ammonia. So it essentially creates this localized alkaline cloud around the bacteria.
Oh, wow. So it builds its own little protective bubble.
It does. This allows it to burrow deep into the protective mucus layer of the stomach, attach to the epithelial cells, and constantly provoke the immune system.
Without ever being fully cleared.
Exactly. The B cells and T cells remain locked in a perpetual state of activation.
That is an evolutionary marvel, a localized alkaline cloud protecting a bacterial invader. But there's a paradox here, right? Because an estimated 50% of the global population carries H. pylori.
Right. It's incredibly common.
Yet only a minuscule fraction of those people ever develop gastric multilymphoma. Why is that?
Well, the bridge between a common bacterial infection and an actual malignant tumor really comes down to the dangers of chronic cellular proliferation.
Because the cells are just dividing too much.
Exactly. When you have immune cells constantly dividing and proliferating over decades to fight an infection they can't quite clear, the statistical probability of a genetic transcription error skyrockets.
It's just a numbers game at that point.
Yeah. Eventually, a single B cell acquires a mutation that gives it a survival advantage. It stops responding to the normal regulatory signals, begins to clone itself uncontrollably, and
And that's the shift. You go from a polyclonal inflammatory response to a monoclonal malignant proliferation.
exactly, that monoclonal expansion marks the birth of low-grade gastric multiple lymphoma.
So the tumor is physically present now, but at this early stage, its survival is still fundamentally tied to the inflammatory environment, right?
Yes, very much so. It still relies on the helper T cells, which in turn are still responding to the H. pylori antigen.
And this dependence is the whole key. This is precisely why we can treat this specific cancer with antibiotics.
Right. If we eradicate the H. pylori, the T cells lose their target. The inflammatory cytokines stop flowing.
So the malignant B cells are deprived of the microenvironmental support they need to survive.
Exactly. The tumor simply regresses and undergoes apoptosis. It basically starves to death without the inflammation.
Okay, I want to frame this with a specific clinical mechanism because this is where the management guidelines throw a really fascinating curveball, especially for you listening if you're prepping for the boards.
Oh, this is a classic exam scenario.
Right. Let's say a patient presents with vague dyspepsia, maybe some weight loss. We do an upper endoscopy and we see an erythematous, maybe slightly ulcerated lesion in the antrum.
Standard presentation.
We biopsy it, and the pathologist confirms it is a low-grade multilymphoma. Now, the clinical reflex is to test for H. pylori, right? We use a urea bluff test or a stool antigen test.
Naturally, you want to find the bacteria you're supposed to kill.
But the clinical guidelines state that even if the patient tests completely negative for H. pylori across two different modalities, the absolute mandatory first step is still a 2-week course of empirical eradication therapy.
Antibiotics and a PPI. Every single time.
Even if the test is negative, that's so counterintuitive.
It seems wrong, but the clinical data supporting that mandate is overwhelming. Empirical eradication therapy works in over 75% of cases, regardless of whether H. pylori was ever detected.
Wait, 75% success rate even when the tests say the bacteria isn't there?
Yeah, when you see a success rate that high for an intervention that seemingly contradicts the diagnostic tests, it forces a reevaluation of the underlying pathology.
So if the tests prove our specific target, H. pylori, isn't there, we still lay down this highly specific chemical net, the antibiotics across the stomach.
Right, because it heavily implies the existence of what we might call copycat arsonists.
Copycat arsonists. Explain that.
Well, the tests might just be missing a really subtle, low-density H. pylori infection. But more intriguingly, entirely different, unidentified bacterial species might be driving that chronic inflammation.
Oh, so it's not just H. pylori that can cause this.
Right. The literature strongly supports this unidentified bacteria theory. We know that MALT lymphomas in other parts of the body are driven by different organisms.
Like what?
For example, Campylobacter jejuni is associated with small intestinal mold, and Chlamydia psittaci is linked to ocular adnexal multi.
Okay, so the immune system reacts similarly to different bugs in different tissues.
Exactly. And the stomach is not a sterile environment. The microbiome of the gastric mucosa is really complex.
So by administering broad-spectrum antibiotics like amoxicillin and clarithromycin, we're basically just drastically altering that whole microbiome.
Wiping out whatever unidentified microbial trigger is maintaining the inflammatory state, even if we don't know exactly what it is.
We're spraying the whole block with water just in case another arsonist is hiding in the bushes.
That's a perfect way to look at it.
Okay, so this empirical antibiotic strike is incredibly effective. But it isn't perfect. I mean, if eradication therapy works 75% of the time, we have to interrogate the cellular mechanics of the remaining 25%.
The cases that do not melt away.
Right. The cases that are fundamentally refractory to the loss of their inflammatory environment. And this points us directly toward a molecular shift within the tumor itself.
Yeah, when a low-grade MALT lymphoma refuses to regress after the microbial trigger is removed, it is almost always because the malignant cells have acquired a hardwired genetic mutation.
They've achieved self-sufficiency. They don't need the fire department or the arsonist anymore.
Exactly. And for anyone managing these patients or preparing for advanced oncological exams, the specific genetic marker you absolutely must evaluate is the T1118 translocation.
Okay, T1118, Q21, Q21. Let's break down the actual mechanics of that translocation because it's fascinating.
That's it.
We are talking about a literal physical breakage and swapping of genetic material between chromosome 11 and chromosome 18.
Right. But the clinical relevance isn't just that the chromosomes look different under a microscope, it's the specific genes that get fused together during this swap.
Right. Chromosome 11 carries the API2 gene, and that normally functions as an inhibitor of apoptosis, correct?
Yes, it stops programmed cell death, and chromosome 18 carries the MALT1 gene.
So when these two break and fuse together, they create a chimeric protein, the API2 multi-1 fusion protein.
And that fusion protein is the engine of resistance. It's the core of the problem.
How does it actually work, though, mechanistically?
The API2 MALT1 complex constitutively activates the NF-kappa B signaling pathway.
Ah, NF-kappa B, that's a huge one.
Yeah. In a normal cell, NF-kappa B is tightly regulated. It only turns on when the cell receives specific external signals telling it to survive and proliferate.
Like signals from those helper T cells we talked about earlier?
Exactly. But the fusion protein locks the pathway in the on position permanently.
Permanently. So the switch is just stuck.
Stuck on. The cell is constantly bombarded with internal signals to survive, to inhibit apoptosis, and to multiply entirely independent of any external helper T cells or bacterial antigens.
So if the fusion protein blocks the natural cascade of programmed cell death, the cell essentially becomes immortal.
Yes.
Which means laying down that chemical net of antibiotics to kill the bacteria won't matter at all. The malignant B cells aren't relying on that inflammatory signal anymore.
They built their own internal survival engine. They're self-sufficient.
Wow. So the presence of the T1118 translocation is highly predictive of antibiotic resistance.
Extremely predictive. Furthermore, it is a harbinger of a much more complicated clinical course because it often correlates with a higher risk of the disease eventually progressing to a high-grade state.
Okay, knowing how critical this is, how do we actually detect it? Because, standard hematoxylin and Yeason staining under a microscope won't show you a chromosomal translocation.
No, H&E won't cut it. You must rely on a molecular pathologist utilizing fluorescence in situ hybridization.
FRCS.
Sure, exactly. They take a slice of the biopsied tissue and apply fluorescent DNA probes that are designed to bind specifically to the API2 and MALT1 gene sequences.
So they literally light up the genes.
Yes. Under a fluorescence microscope, a normal cell will show distinct separate signals for each gene. But in a cell with the translocation, the signals overlap or merge, literally lighting up the genetic mutation.
Okay, this presents an intense clinical decision point, and I want you listening to really picture this scenario. Let's say you are managing a patient. The initial biopsy confirms MALT lymphoma.
Okay.
The molecular pathologist runs the FESH tests and reports that the T1118 translocation is vividly present. So we have absolute proof that the tumor has the immortality cheat code.
We know for a fact it will not respond to antibiotics.
Right. So does the multidisciplinary team still subject the patient to a 2-week course of heavy antibiotics, or do they bypass that futile step and escalate immediately to localized radiation or systemic therapy?
This is a great exam question.
Yeah.
The strict clinical guidelines mandate that you still proceed with the H. pylori eradication protocol. You still prescribe the antibiotics and the PPI.
Even with genetic proof of resistance, that is so wild. The rationale there has to be twofold, right?
It is. First, eradicating a concurrent H. pylori infection, if one actually exists, heals the surrounding non-neoplastic mucosa.
Okay, so it resolves the baseline gastritis.
Right. And that reduces the risk of bleeding or ulceration from the normal tissue, which is important.
But there's a second reason, and it speaks to the biological pacing of the disease, right?
Yes. Low-grade MALT lymphomas, even those with the T1118 translocation, are notoriously indolent. They are incredibly slow-growing.
So we have the luxury of time.
Exactly. Administering the antibiotics does not compromise the patient's oncological outcome. The tumor isn't going to suddenly explode in those 2 weeks.
So what does the positive T1118 result actually provide if it doesn't change the immediate first step?
It provides foresight. Normally, the post-antibiotic phase involves months of expectant observation.
Right. You just kind of wait and see.
If you are blind to the genetic status, you and the patient are simply hoping for regression. You're just waiting in the dark.
Ah. But with a positive T1118 result, the multidisciplinary team, the surgeon, the radiation oncologist, the medical oncologist, they can preemptively plan.
Exactly. Your regression is highly unlikely, so you use those observation months to discuss the logistical and physical realities of involved site radiation therapy.
Or targeted immunotherapy.
Right. You get the ball rolling rather than being caught off guard when a follow-up endoscopy shows an unchanged tumor 6 months later.
Expectation management backed by molecular foresight. I love that. It allows the clinician to prepare the secondary strikes while the tumor slowly simmers.
But, and this is big but, that simmering cannot be ignored indefinitely.
Because genetic instability is cumulative.
Yes. If early interventions fail, the slow-moving indolent tumor can acquire further mutations, leading to a catastrophic biological shift.
Which brings us to the histopathology. We need to look under the microscope to understand exactly how this low-grade MALT morphs into the highly aggressive diffuse large B-cell lymphoma, or DLBCL.
The distinction between low-grade and high-grade disease is really the fulcrum upon which all treatment algorithms balance.
So let's paint the picture. When a pathologist looks at a classic low-grade MALT lymphoma, what are they seeing?
Well, the architecture of the stomach wall is altered, but it's still recognizable. You see an infiltration of what we call centrocyte-like cells.
Centrocyte-like cells, what do those look like?
They are small to medium-sized lymphoid cells. They have these slightly irregular cleaved nuclei. You will also see a heavy presence of plasma cells.
Which makes sense, given the tumor's origin in a mucosal immune response. It's an immune organ trying to do its job, just badly.
Exactly. But the defining structural feature of this low-grade phase is the lymphopithelial lesion.
This is a huge buzzword for the boards, lymphoepithelial lesions.
Absolutely. Because this isn't just a passive infiltration of cells. The malignant centrocyte-like cells actively invade the normal gastric glands and crypts.
They cluster together and essentially destroy the epithelial architecture from the inside out.
Yes, those lymphopithelial lesions are the hallmark of MALT. Now, alongside the physical morphology, the pathologist must define the immunophenotype using flow cytometry and immunohistochemistry.
Right. They are looking at the cluster of differentiation, the CD markers, expressed on the surface of the tumor cells.
And low-grade MALT T cells are definitively B cells. So, logically, they will strongly express B-cell markers.
CD19, CD20, and CD79A.
Exactly. They are universally CD20 positive.
But the diagnosis often hinges on what the cells do not express, right? Like if I'm an FRCS candidate analyzing a pathology report, I am scanning specifically for the negatives.
You have to. The cells must be distinctively negative for CD5, CD10, CD23, and cyclin D1.
CD5 and CD10 negative. Why is that negative profile so vital?
Because it rules out other, far more dangerous lymphomas that can occasionally present in the gastrointestinal tract.
Ah, like mantle cell lymphoma.
Right. If the cells express CD5 and cyclin D1, you are likely looking at mantle cell lymphoma, which requires a radically different, much more aggressive systemic approach.
And what about CD10?
The CD10 negativity helps differentiate MALT from follicular lymphoma. The precise profiling guarantees you're actually treating the right disease.
Okay, so CD20 positive, CD5 and CD10 negative. That is our solid baseline for the slow-moving MALT.
Yes.
But the biology can tip. The literature indicates that in roughly 2 to 8% of gastric MALT cases, overt transformation to DLBCL occurs.
Yeah, that 2 to 8% is a terrifying shift. The tumor acquires enough secondary genetic hits to just shift gears entirely.
We're talking about mutations in the P53 tumor suppressor gene, right? Or translocations involving the MYC oncogene.
Exactly. And it's also really important to note that DLBCL can arise de novo. It doesn't always have to transform from MALT. It can present as a high-grade tumor from the very first biopsy.
So whether it transforms from a pre-existing MALT or arises de novo, the microscopic landscape is just obliterated.
Completely. Those delicate centrocyte-like cells vanish. They're replaced by dense, diffuse sheets of medium to large lymphoid cells.
The proliferation is chaotic. It's destructive.
The cells feature large vesicular nuclei, prominent nucleoli, and scant cytoplasm. They lose any semblance of orderly infiltration.
They don't care about the glands anymore.
No, they simply expand rapidly through the lamina propria, violently effacing the surrounding tissue.
Their physical appearance perfectly reflects their biological agenda. They are no longer maintaining the slow, reactive pretense of a MALT lymphoma. They are entirely focused on rapid division.
And their CD marker profile shifts to reflect this aggressive activated state as well.
They still retain the core B-cell markers, right? Like CD20.
Yes, CD20 remains strongly positive,
Mm.
which is crucial for targeted therapies later on. But they now exhibit an activated B-cell phenotype.
Meaning they strongly express PX5?
Exactly. And this is where prognostic substratification becomes critical. In approximately half of these high-grade cases, the transformed cells will begin expressing the oncogenes BCL6 and BCL2, as well as the marker CD43.
And pathologists divide DLBCL into morphological subtypes, don't they?
They do. You have the centroblastic variant, which is more common and generally has a slightly better response to chemotherapy.
And the other one?
The immunoblastic variant. This is composed of massive cells with single central nucleoli, and it carries a notoriously poor prognosis.
The histopathological shift from small centrocytes to sheets of large immunoblasts mirrors the most terrifying clinical aspect of this transformation.
Emancipation.
Exactly. When the tumor is low-grade MALT, it relies on the bacterial antigen. When it transforms into DLBCL, it emancipates itself completely from the environment.
It no longer requires H. pylori. It no longer requires the helper T cells. It is self-sustaining and incredibly violent.
The clinical implications of this biological independence are just staggering.
You cross a threshold where conservative management becomes medical negligence.
Right. Expectant observation is entirely off the table.
Because when the tumor achieves independence and rapid proliferation, the physical integrity of the stomach is immediately threatened.
The risk of massive gastrointestinal hemorrhage spikes as the tumor erodes through major mucosal vessels.
And the risk of full-thickness gastric perforation becomes imminent as the sheets of cells destroy the muscularis propria.
So the moment the pathology report reads diffuse large B-cell lymphoma, the entire paradigm shifts from antibiotics to aggressive systemic chemoimmunotherapy.
We deploy heavy-duty regimens designed to halt rapid cellular division. The standard of care pivots to RCHOP.
RCHOP. Let's spell that out for the listeners. That's a combination of the monoclonal antibody rituximab combined with cyclophosphamide, hydroxydonorubicin, oncovin, and prednisone.
Or alternatively, regimens like bendamustine and rituximab might be used.
But either way, these are profound systemic cellular poisons aimed at obliterating a fast-moving target.
Exactly. But before a medical oncologist can calculate the dosage of RCHOP, or before a radiation oncologist can calibrate their linear accelerator for localized disease, the multidisciplinary team faces a massive geographical problem.
Right. We know the biology of the tumor now, but we must know precisely how far the rogue cells have spread.
Staging is the absolute prerequisite for any definitive treatment algorithm.
And this brings us to a significant clinical hurdle, especially for surgeons. The traditional tools of surgical oncology basically fail us when dealing with extranodal lymphomas.
Yeah, they really do. Any surgeon is intimately familiar with the TNM staging system. Tumor, node, metastasis.
It is the absolute bedrock for staging solid epithelial tumors. Gastric adenocarcinoma, colorectal cancer, breast cancer, you use TNM.
Because TNM relies on the premise that a tumor originates in the epithelial lining, grows progressively deeper through the anatomical layers of the organ wall, and spreads in a highly predictable stepwise fashion.
Right. It goes through regional lymph node basins before disseminating distally. It follows a predictable roadmap.
But lymphomas inherently violate the premises of TNM staging. Lymphoma is a systemic disease of the lymphatic network.
Even when it presents extranodally, meaning the primary mass is located outside a lymph node, like here in the submucosa of the stomach, it does not respect the anatomical boundary.
Or the predictable stepwise spread of an epithelial carcinoma. Applying TNM to a lymphoma provides a totally inaccurate assessment of the disease burden.
Okay, so if TNM is obsolete here, the natural reflex for a lot of clinicians is to reach for the Ann Arbor staging system, right? The classic framework used for Hodgkin and non-Hodgkin lymphomas.
Stage I localized, stage 4 disseminated, with A and B symptom modifiers.
Yeah. Why doesn't that work here?
Ann Arbor is excellent for nodal lymphomas, but it falls way short for primary extranodal sites like the stomach. It lacks the granularity needed to describe exactly how a primary extranodal tumor interacts with the surrounding visceral organs.
So if a gastric lymphoma is physically pushing against the spleen, Ann Arbor struggles to accurately reflect the localized surgical and radiotherapeutic implications of that specific invasion.
Exactly. It just wasn't built for that.
So because of these limitations, the global oncological community relies on a highly specialized framework. And if you're being tested on gastric lymphoma staging, the definitive standard is the modified Lugano staging system.
Modified Lugano. This system was specifically designed to capture the unique geographical behavior of gastrointestinal lymphomas.
Let's walk through the delineations carefully because the nuances matter here.
Okay, so stage I dictates that the lymphoma is strictly confined to the gastrointestinal tract.
Meaning it could manifest as a solitary primary lesion in the gastric antrum, or, and this is key, it could present as multiple non-contiguous lesions scattered throughout the stomach.
Right, as long as the disease has not breached the external serosa or spread to any lymph nodes, it is still stage 1.
Okay, so stage I is strictly internal to the GI tract. Got it. As the disease progresses, we move to stage 2, which indicates the lymphoma is extending beyond the stomach into the abdominal cavity.
And stage 2 is highly stratified. This is where people get tripped up.
Let's break it down.
If the disease has spread to the immediate local paragastric lymph nodes, it is classified as stage 1. That's Roman numeral 2, followed by the number 1.
Stage I, local nodes. Okay, and if it goes further?
If the lymphoma continues its march down the lymphatic highway, reaching distant abdominal nodes like the mesenteric or periaortic chains, the classification advances to stage I2.
Okay, I1 is local, II is distant abdominal nodes. But the lymphoma might not just spread via the lymphatics, right? It might grow outward, physically breaching the visceral peritoneum.
Yes, and this introduces the E modifier.
Stage 3.
Stage 3 is assigned when the lymphoma penetrates through the gastric serosa and directly invades adjacent abdominal organs or tissues.
So it's physically eating into the pancreas or the spleen?
Exactly. And a critical clinical requirement when assigning the stage is specifying the exact site of invasion. You do not just document stage 3.
You have to be specific.
You must document stage IE, pancreas, or stage 3, transverse colon.
Why is that specificity so mandatory?
Because that exact geographical mapping is absolutely vital for the radiation oncologist who is plotting the treatment field, and it's vital for the surgeon who might have to manage a fistula or a multi-organ complication later on.
That makes total sense. So we have stage I confined, stage I1 local nodes, stage II distant abdominal nodes, and stage IE direct adjacent organ invasion. Now, clinical logic might suggest that we now define stage 3. But this is the massive trap built into the modified Lugano system.
It's a huge trick question on the boards.
There is no stage 3.
None. The system jumps directly from stage 3 to stage 4.
Why? Why skip a number?
The omission of stage 3 is a deliberate reflection of lymphoma biology. In traditional systems, stage 3 often represents disease on both sides of the diaphragm, or a specific intermediate spread.
But for a primary gastric lymphoma, that intermediate spread doesn't really matter clinically.
Exactly. Once the disease disseminates beyond the regional abdominal nodes or direct local organ invasion, the prognosis and the systemic treatment approach completely unify.
A clinically distinct middle ground just does not exist.
Right. Stage 4 comprehensively denotes a lymphoma with widely disseminated extranodal involvement, such as spread to the bone marrow or lungs, or the presence of supradiaphragmatic nodal involvement.
The moment the disease crosses the diaphragm into the mediastinal or cervical nodes, it is definitively stage 4 systemic disease. Boom, done. Okay, so modified Lugano provides this brilliant satellite map. It shows you the geographic reach of the invading cells across the body, but some high-volume specialized centers argue that a satellite map isn't quite enough.
It tells you if the local nodes are involved, but it doesn't tell you the precise physical footprint of the primary tumor within the stomach itself.
Right. For that level of detail, clinicians employ an adjunctive framework known as the Paris staging system.
The Paris system utilizes endoscopic ultrasound, or EUS.
Which is such a cool piece of technology.
It is. EUS allows the gastroenterologist to place a high-frequency ultrasound probe directly against the gastric mucosa,
generating a high-resolution cross-sectional image of the 5 distinct layers of the stomach wall.
Exactly. The Paris system classifies the tumor based on exactly how deep it is burrowed into those 5 layers.
I love thinking about it like ground-penetrating radar. Modified Lugano shows you the spread across the country, right? The satellite view. But the Paris system shows you how deep the trenches are dug on the actual initial battlefield.
That's a perfect analogy. It differentiates a tumor confined to the superficial mucosa and submucosa from one that has invaded the muscularis propria or the subserosa.
And that depth has immense prognostic value, doesn't it?
Huge value. Low-grade MALT lymphomas that are restricted to the mucosa and submucosa have an outstanding prognosis. 10-year survival rates are pushing 90%.
Wow, 90%.
But once the tumor invades the muscularis propria, The risk of concurrent nodal involvement and the risk of eventual transformation into high-grade DLBCL escalates dramatically.
So you really need both the Lugano satellite map and the Paris ground-penetrating radar to form a complete three-dimensional clinical picture.
You absolutely do.
Okay, so armed with the molecular genetics, the histopathological subtype, and the precise staging maps, we are finally positioned to construct the definitive management algorithm.
The master plan.
Right. We know the empirical antibiotic step, we covered that, but what happens next? How do we handle the surveillance? And more importantly, how do we escalate care for the cases that refuse to yield?
Let's establish the surveillance protocol first. Say you have a patient with limited stage disease, Lugano stage I or II1, who has completed their 2-week course of H. pylori eradication therapy.
You don't just discharge this patient, right?
Oh, absolutely not. The physiological clearing of aberrant lymphoid tissue is an incredibly slow biological process.
Because the body has to dismantle that whole forward operating base it built.
Exactly. It requires months for macrophages to clear the apoptotic cells and for the gastric mucosa to remodel itself. Therefore, the first follow-up EGD esophagogastroduodenoscopy is scheduled 3 to 6 months after the completion of antibiotics.
3 to 6 months. That is a long wait.
It is. And this follow-up EGD is not just a quick visual inspection. The endoscopist must adhere strictly to the Sydney protocol.
The Sydney protocol for gastric mapping. Because MALT lymphoma can be multifocal and patchy, right?
Yeah, it often presents as subtle mucosal irregularities rather than a distinct, obvious mass.
So the endoscopist must take multiple systematic biopsies from the antrum, the corpus, the fundus, and any macroscopically abnormal areas. They are mapping the entire stomach.
Right. And those biopsies are evaluated to assess true histological remission. The visual disappearance of an ulcer is not enough.
Because the cancer could still be hiding microscopically.
Exactly. The pathologist must confirm the absence of dense lymphoid infiltrates and the resolution of those lymphoepithelial lesions we talked about.
And the literature demonstrates that complete histological remission can take anywhere from 1 to 14 months to manifest.
Up to 14 months. It is a protracted waiting period. It requires a lot of patience from both the clinician and the patient.
Furthermore, remission cannot be declared based on a single EGD, right?
No. The protocol requires 2 consecutive endoscopies demonstrating total resolution.
And once complete response is finally achieved,
The patient transitions to long-term surveillance, EGDs every 6 months for 2 years, and then annually or every 18 months thereafter.
because there is a lifelong risk of relapse.
Unfortunately, yes.
Okay, so that is the pathway for success. That's the happy path. But we must address the complex scenarios, the ones that keep you up at night.
The refractory cases.
Right. What happens if the patient presents with limited stage MALT, but they are definitively H. pylori negative from the start, and maybe the FISH test showed that T1118 translocation is present? Or what happens if we wait the full 14 months post-antibiotics and the gastric mapping shows absolutely no regression?
The tumor is officially refractory. In these cases, limited stage, H. pylori negative, or strictly refractory MALT lymphomas. The definitive second-line standard of care is involved site radiation therapy, or ISRT.
ISRT, so we bring in the radiation oncologists.
We do. They map the stomach and the immediate local draining lymph nodes. Using modern, highly conformal radiation techniques, they deliver a moderate dose, typically around 24 to 30 gray.
24 to 30 gray, and how effective is that?
Incredibly effective. MALT lymphoma cells are highly radiosensitive. ISRT achieves local control and complete histological remission in over 95% of these localized refractory cases.
Greater than 95% remission with localized radiation. That is a phenomenal efficacy rate.
It really is. It's the curative backup plan.
But radiation isn't suitable for everyone. I mean, a patient might have severe baseline renal or hepatic comorbidities or prior abdominal radiation exposure.
Or perhaps the disease is just too diffuse within the abdomen for a safe radiation field. You can't radiate the whole abdomen without massive toxicity.
Right. So in those instances, the algorithm shifts from radiological intervention to targeted immunotherapy.
Specifically, the use of single-agent rituximab,
Okay, let's unpack rituximab. It is a chimeric monoclonal antibody.
engineered to seek out and bind specifically to the CD20 transmembrane protein.
Tying back to the histopathology from earlier, we established that MALT lymphoma cells strongly express CD20.
Exactly. It's a perfect lock and key. When rituximab binds to the tumor cell, it triggers a cascade of immune responses.
Antibody-dependent cellular cytotoxicity and complement-dependent cytotoxicity.
Basically, it flags the malignant B cells for destruction by the patient's own immune system.
It is a highly effective, targeted biological weapon. But any systemic therapy carries profound physiological risks.
And this brings us to a massive non-negotiable safety protocol.
Right. The clinical guidelines mandate an absolutely critical check before the first drop of rituximab ever enters the patient's vein.
Rituximab is brutally efficient at depleting the B-cell population. That's its job.
But by wiping out the humoral immune system, it removes the immune pressure that suppresses latent viral infections.
This is the danger zone. If a patient harbors a dormant hepatitis B infection, the sudden loss of B cells allows the virus to reactivate violently.
Hepatitis B reactivation, and that can trigger fulminant acute liver failure.
Yes, which carries a severe mortality risk. You could literally cure their lymphoma and kill them with liver failure.
Oh, wow. So what's the mandate?
It is a strict requirement to screen every single patient for hepatitis B surface antigen and core antibody, alongside hepatitis C and HIV serology, prior to initiating rituximab.
And if they test positive for latent Hep B,
They require concurrent antiviral prophylaxis. You have to protect the liver before you treat the cancer.
such a vital clinical pearl for the exam in the ward. Test the liver serology before attacking the CD20.
Always.
Okay, but what if rituximab fails? Or what if the disease is widely disseminated stage 5E but still low grade?
Then the management enters highly specialized territory, salvage regimens.
Like combining rituximab with immunomodulators like lenalidomide?
Exactly. Or deploying oral kinase inhibitors targeting the BTK or PI3K delta pathways. But honestly, at this echelon of care, decisions must be driven by multidisciplinary tumor boards at high-volume oncological centers.
And clinical trial enrollment is strongly encouraged at that point.
Definitely.
Okay, so looking at this entire algorithm, we have outlined antibiotics, prolonged surveillance, localized radiation, monoclonal antibodies, and targeted kinase inhibitors.
Notice what's missing.
The conspicuous absence in this entire modern algorithm is the scalpel.
It is nowhere to be found.
And this brings us back to our surgical listeners. A generation ago, a surgeon would have performed a gastrectomy on day 1.
They would have taken the stomach out.
Today, with radiation achieving 95% remission rates for localized disease without the severe nutritional, metabolic, and physiological morbidity of removing the stomach, surgical resection for gastric lymphoma has been rendered completely obsolete as a primary curative intent.
It's totally off the table for primary treatment.
So when does the surgeon actually scrub in? What is their role?
The surgeon serves as the ultimate structural safety net. You are no longer managing the biology of the tumor. You're managing the mechanical catastrophes it can cause.
You get the call when the anatomy fails.
Exactly. The surgeon is called when the disease process, or sometimes the rapid necrosis of the tumor caused by aggressive chemotherapy, compromises the physical integrity of the gastrointestinal tract.
You get the call for the classic triad of gastrointestinal emergencies.
Right. First, massive acute upper GI bleeding.
If a bulky tumor erodes into a major submucosal artery and the interventional endoscopist cannot achieve hemostasis with clips, epinephrine injection, or thermocoagulation,
Then the surgeon must perform a life-saving exploratory laparotomy to ligate the vessel or perform a wedge resection. You have to stop the bleeding.
okay, bleeding is number 1. What's the second emergency?
Full thickness perforation.
Whether that's driven by aggressive DLBCL invading through the muscularis propria or by the rapid melting of a tumor during RCHLP therapy, leaving a massive defect in the wall.
Either way, gastric contents spilling into the peritoneum creates a lethal peritonitis. The surgeon must intervene immediately to wash out the abdomen, repair the defect, or perform a partial gastrectomy.
It's purely damage control. And the third part of the triad.
Gastric outlet obstruction. A dense fibrotic tumor in the antrum or pylorus can physically block the passage of food from the stomach into the duodenum.
And if endoscopic balloon dilation or stenting fails?
The surgeon must bypass the obstruction, typically by creating a gastrojejunectomy, allowing the patient to maintain enteral nutrition.
Okay. So aside from managing those 3 emergencies, bleeding, perforation, and obstruction, is there any other conceivable role for surgery?
Only in the exceptionally rare scenario of localized disease that is utterly refractory to every single modality: antibiotics, radiation, immunotherapy, and chemotherapy.
And the patient is severely symptomatic but refuses palliative care.
Right. In those extreme 1 in a million outliers, a multidisciplinary board might sanction a resection, but it is the absolute definition of a last resort.
It requires a profound psychological evolution for a surgical oncologist.
It really does.
I mean, you train to be the curative element. You are the one who physically extracts the pathology. But for gastric lymphomas, the highest level of patient care dictates that you defer to the biology.
You trust the medical and radiation oncologist to dismantle the tumor at the cellular level?
While you stand vigilant on the periphery, ready to intervene only when the structural anatomy collapses.
It is a true testament to precision medicine. We have evolved from anatomic brute force to targeted biological manipulation.
It's beautiful, honestly. All right, let's synthesize the definitive takeaways from this deep dive. If you are stepping into a board examination tomorrow or a tumor board, these are the non-negotiable principles you must command.
The absolute must-knows.
First, the etiology and the empirical mandate. Gastric MALT lymphoma is born from chronic inflammation, predominantly driven by H. pylori.
And regardless of whether non-invasive testing detects the bacteria, the absolute first step is a 2-week course of empirical eradication therapy antibiotics and a PPI, because it cures the neoplasm in 75% of cases.
Second, the molecular checkpoint. The T1118 translocation fuses the API2 and MALT1 genes, creating a protein that permanently inhibits apoptosis.
Its presence, verified by FESH, guarantees the tumor will be refractory to antibiotics. But remember the exam trick.
Yeah.
You still administer the eradication therapy, you just use the time to preemptively plan for radiation or immunotherapy.
Perfect. Third, the histopathological tipping point. Low-grade MALT features centrocyte-like cells and lymphoepithelial lesions with a CD20 positive, CD5 negative, CD10 negative profile.
But it can transform into diffuse large B-cell lymphoma, characterized by sheets of large cells, an activated B-cell phenotype with PX5, and complete biological independence from the bacterial antigen.
And that transformation demands immediate escalation to systemic RCHOP chemoimmunotherapy. You don't wait.
Fourth, the staging geography. Discard TNM, discard Ann Arbor.
They are useless here. Utilize the modified Lugano system, which classifies disease from stage 1 to stage IE based on localized or distant abdominal spread.
It entirely skips stage 3, remember that. And it designates systemic spread as stage 4.
And pair Lugano with the parastaging system, utilizing endoscopic ultrasound to map the precise depth of invasion into the gastric wall layers, the satellite MAO, and the ground radar.
Exactly. And finally, the algorithmic management. For H. pylori negative or refractory limited stage disease, rely on involved site radiation therapy for a 95% local control rate.
If utilizing rituximab instead, mandatory screening for hepatitis B is required to prevent fatal viral reactivation.
And the surgeon's scalpel is strictly reserved for managing the devastating complications of bleeding, perforation, and obstruction.
It is a beautifully complex algorithm that respects the microscopic origins of the disease while leveraging the full spectrum of modern oncological tools.
It really is an incredible success story of modern medicine.
It is. But as we close this deep dive, I want to leave you with a broader thought to really interrogate, something to mull over.
Okay.
We just spent an hour discussing a literal, histologically verified malignant cancer that can be entirely cured, made to vanish, simply by administering a generic course of amoxicillin and clarithromycin to alter the bacterial environment.
Right. It forces us to re-examine the rigid boundaries between infection, chronic inflammation, and oncology.
Precisely. If a monoclonal proliferation of immune cells in the stomach is just a misguided reaction to an unseen pathogen, we have to look at the wider landscape of slow-growing extranodal tumors across the entire body.
It makes you wonder.
How many other entities that we currently classify as cancers, bombarding them with systemic poisons and radiation, are actually just hyperactive immune responses locked in a localized battle?
We might be treating the smoke and ignoring the fire in other diseases, too.
Exactly. How many other rogue biological fires are burning, waiting not for a linear accelerator or a surgical resection, but for us to discover the exact right, simple, antimicrobial key to turn off the inflammatory alarm?
That is a profound question.
Keep asking those questions, keep pushing the boundaries of the biology, and we will see you on the next deep dive.